Thank you. I'm happy to be here today. My disclosure, certainly my affiliation was already mentioned, and I would just disclose that I'm serving as the scientific advisor for the ILSI North America Caffeine Working Group, and collaborated on the review paper, or a review paper on this topic with support from the Caffeine Working Group, and I have no research funding currently pertaining to caffeine. So as we begin to review this topic, I think it's useful to first consider the issues that have fueled the concern about caffeine and reproductive health. Certainly, it's already been established that caffeine exposure is prevalent, and so it's also prevalent in women of reproductive age. And surveys that have included consumption patterns among pregnant women indicate that the majority, or as much as 68%, will continue caffeine consumption after becoming pregnant. But we also acknowledge that there are changing intake patterns during pregnancy, particularly notable during the early weeks of pregnancy when symptoms of pregnancy may be increased. Data from over 8,000 controls from the National Birth Defects Prevention Study have reported intake patterns during the year preceding the pregnancy included in the study. And so from this reported distribution, if we consider the current recommendations for daily amounts of caffeine during pregnancy, and we consider that this limit is currently specified between 200 and 300 milligrams per day, then we find that 11 to 23% of women are likely to exceed these recommendations in their early weeks of pregnancy, particularly if we consider the fact that 50% of pregnancies are unplanned. So concerns about this prevalent exposure are supported by the plausibility of potential effects on the fetus. So while the actual mechanism of caffeine, or by which caffeine could alter fetal growth and development, these mechanisms are not specifically known, but we do know that caffeine is rapidly absorbed, it crosses the placental barrier, it's poorly metabolized by the fetus, and we know that the half-life of caffeine increases during pregnancy from about 4 hours in the pre-pregnancy and early pregnancy state to as high as 18 hours in the third trimester. And this can lead to an accumulation of circulating caffeine concentrations in the mother and the fetus. And so this is attributed to the reduced activity of the main enzyme controlling caffeine metabolism, which is cytochrome P450 1A2. There's also other evidence concerning the effect of caffeine on increased catecholamines, which could lead to uteroplacental vasoconstriction. Caffeine inhibits phosphodiesterases, which increase cyclic AMP, which could interfere with fetal growth and development. And of course, we already heard about the blocked adenosine receptors, which could lead to hypoxia during pregnancy. So efforts to evaluate caffeine as a risk factor for adverse reproductive and perinatal events have resulted in numerous studies ranging from delayed conception to delivery endpoints, and even more recently on postnatal events. But the predominant bulk of the research has focused on these 5 areas. So here I've attempted to estimate the number of studies or evaluations that have addressed these topics over the last 40 years. And so these counts, they're my estimations based on my review of the literature. They're not mutually exclusive categories because some studies have evaluated multiple outcomes. But at a glance, this would demonstrate that the research to date has focused predominantly on indicators of fetal growth, and this is followed by studies of pregnancy loss, either early miscarriage or late fetal death. Most studies, or many studies of fetal growth, have also incorporated assessments of gestational age, so that tends to inflate the number of evaluations conducted on preterm delivery and gestational age. So the quality of the studies, of course, has varied given their observational nature. But even among the most rigorous studies, there are common methodological challenges that may result in biased estimations. And so this can contribute to a pattern of inconsistent findings that we tend to observe. So these methodological concerns, of course, they complicate our efforts to interpret the strength of the evidence for a causal relationship with caffeine. So in an attempt to present a useful overview during this talk, my approach is to highlight some of the key or recent findings while primarily focusing this discussion on the methodologic issues that have hindered interpretation. So I'll primarily discuss these methodological issues in the context of studies on fetal growth restriction and pregnancy loss, since these are the two outcomes that tend to be the center of most discussion. So results of prior studies on fetal growth restriction have been roughly split half and half. Studies reporting weak associations with small for gestational age and reduced birth weight, and half reporting no associations. So in one of the most recent studies conducted by Sengpiel, results from a large, very well-conducted prospective cohort study were reported for a Norwegian population of pregnant women. Over 59,000 women were included in this study, and these women had otherwise uncomplicated pregnancies. So this study incorporated a comprehensive assessment of caffeine intake from all sources, and this was assessed at multiple time points. A food frequency questionnaire was administered around 22 weeks gestation, and the purpose of this was to attempt to identify habitual use in the first 4 to 5 months of pregnancy. But also beverage consumption was assessed at 17 weeks as well as 30 weeks. And so what's interesting, we have a number of studies that have suggested that the primary source of caffeine during pregnancy is coffee. And of course that depends on the particular population being studied. But this study reported that the major source of caffeine tended to differ in the low and the high intake groups. So when total intake was categorized in quintiles, then coffee was the major source of caffeine exposure in the upper 2 quintiles, black tea in the 2nd and 3rd quintile, and chocolate in the 1st quintile. Because there's no consensus on the definition or the use of standard growth curves for defining small for gestational age, one strength of this particular study is that it incorporated 3 different definitions of small for gestational age that were based on different growth curves or different methods for estimating the growth curves. And so these 3 columns represent the 3 methods. The far left-hand side is the Marsal method, which was ultrasound-based. The middle was the population-based growth curves. And then the column to the far right used customized growth curves. And the use of the customized growth curve has been endorsed for its ability to distinguish between what are constitutionally small but otherwise healthy deliveries from those that are really failing to reach their inherent growth potential. And so you can see if you focus on the bottom table that the results observed, the odds ratios observed for an association between caffeine use and small for gestational age were positive and statistically significant, but quite modest, ranging from about a 10% increase odds for those in the lowest exposure category to approximately a 60% increase odds. So when caffeine was assessed as per 100 milligrams of caffeine intake, that estimate ranged from about 11 to 18% increase odds of small for gestational age. So these results are comparable to pooled estimates from a recent meta-analysis, but I'm displaying these results, but I want to emphasize that we really need to use caution when we're interpreting results of meta-analyses from observational studies. actually we need to critically review all meta-analyses, just as we would critically review individual studies for their inclusion criteria and their analyses. But in this case, the studies that are combined are representing a very heterogeneous group in terms of the quality of the exposure assessment, the timing of the exposure assessment, the outcome methods for defining the outcome ascertainment, covariates that were controlled in these analyses, even the study design and measures of association, whether they calculated odds ratios versus directly calculating risk ratios. And so there's some concern, and some would argue that observational studies should never be combined in this manner. But certainly there's a movement to attempt to use these methods to better understand patterns when there are inconsistencies across studies. So I think what's particularly perhaps useful is the display of the forest plot, which provides some visual to identify how studies have been relatively inconsistent over time. Generally, there's a positive point estimates being reported, but these are often weak, and about half do not achieve statistical significance. So combining, actually, one thing I should mention about these meta-analyses, of course, and the authors recognized these limitations. They couldn't adequately address confounding, and of course the timing of the exposure assessment varied across studies. In the same meta-analyses, the authors evaluated differences in birth weight as well, and so we see that here you can see the greater variation in terms of the magnitude and the direction of the differences in birth weight that have been reported. So the pooled estimate here represents a decrease in birth weight associated with the highest caffeine consumption category of greater than 350 milligrams per day, and that reduction estimated at 69 grams. So when we attempt to interpret the evidence for a causal association between caffeine and fetal growth restriction in the midst of these inconsistencies, we have to consider other possible explanations for these observed associations. And certainly one of the major limitations that we face in all caffeine studies is the difficulty of measuring caffeine consumption. Typically we're relying on self-reports, which are prone to error and prone to not necessarily intentional misreporting, but just the lack of ability to accurately recall consumption patterns over time. And then these efforts to measure caffeine consumption are further complicated by the need to consider multiple sources of caffeine, the specific serving size, the product brand, the method of preparation, all of these factors that influence the actual caffeine content of a beverage or food serving. And then with pregnancy, of course, we have changing exposure patterns over time, particularly in the early weeks of pregnancy. And so the difficulty of attempting to measure caffeine exposures during the etiologically relevant period of exposure becomes even more complicated or difficult to obtain. And then, of course, studies have been criticized for their lack of ability to consider inter-individual variation in caffeine metabolism, which could be important for identifying potentially susceptible populations. So the authors of the Norwegian study that we discussed previously, they did attempt to address concerns about measurement error by incorporating a validation sub-study. The sub-study included 119 women, and so in this study they're comparing their food frequency questionnaire, which was a retrospective assessment that covered about 8 weeks of early pregnancy, weeks 5 through 12. And they compared that with a prospective 4-day food diary. Why not just go ahead and use the food diary on the entire population? Well, as you can imagine, that's, it's cost prohibitive, it's time intensive for the study subjects, and so typically these methods are not easily implemented in large populations. And so one way to address our concerns about our measurement error is to conduct validation studies. But surprisingly few of the studies in this area of caffeine and reproductive health have actually reported results from such studies. So in this study, the Spearman correlation was reported at 0.7, which was interpreted as reasonably strong agreement between the two methods. But you can see from this Bland-Altman plot, which is comparing, on the y-axis, we have the difference between the two measures compared to the mean intake as averaged across the two measures. And certainly from this plot, you can see that, as we would expect, we're going to have some variability between the two measures. But it appears to be increasing. That variability appears to be increasing with increasing consumption patterns. And so certainly some proportion of study participants could be misclassified by as much as 150 milligrams per day based on these data. Another large prospective cohort study of fetal growth restriction, which was conducted in the UK, they also incorporated a validation study by comparing their comprehensive assessment tool, similar to a food frequency questionnaire, with a 3-day prospective food diary. And so unfortunately, this validation study only included 24 women, but it's a valuable step forward in attempting to assess the quality of the measurements that we're using in these studies. And so here, when we take a look at the comparison, the authors split the distributions at the median in order to make categorical comparisons regarding lower exposures versus higher exposures. And the kappa correlation coefficient for the entire group was reported at only 0.5, reflecting only modest or moderate agreement across these categories of exposure. Now, this did improve somewhat to 69% when they restricted that assessment to those that were interviewed at a time period closer to the reporting period, so before 15 weeks of gestation, when they were in fact reporting on exposures from between 5 and 12 weeks of pregnancy. So certainly the fact that caffeine consumption is difficult to measure, that's well recognized and an accepted limitation of most epidemiologic studies of caffeine exposures. But I think it's fair to say that the potential impact of exposure misclassification in these studies, the impact is perhaps less appreciated. So one concern we have about the validation studies that were reported is that the studies that have resulted out of these cohorts have gone on to report these instruments as validated, which is a very loosely defined term. So, so we really need more information because a correlation is not sufficient. A correlation only provides information concerning the linear association between the two measures. And so ideally, we'd like to have more information, sensitivity and specificity of these measures. So here's a publication recognizing, and actually it's surprisingly relatively recent, that's emphasizing the fact that measurement error may in fact be the most influential source of bias in most epidemiologic studies, even though it's confounding that gets the bad rap and most of the attention, that we need to give more attention to this potentially more influential source of bias. So I think in order to better appreciate the potential impact that this source of bias may have on our observed associations between caffeine and reproductive outcomes, I think it'd be helpful to just take a moment to briefly review this concept of misclassification. So if we're collecting information on caffeine exposure, right, our measurement is a function of the accuracy of the measurement tool. Right, so certainly here we're using a very simple scenario that if we were to consider the distribution of caffeine exposure across outcome categories, what we have is a 2-by-2 contingency table. And so what we recognize is that we cannot actually observe the truth, but our approximation of the truth is dependent on the accuracy of this measure, and that's defined in terms of the sensitivity and the specificity of that measure. So I promise I'm not going to throw out any other formula, but this just reminds us that what we're observing in our study is actually some combination of individuals who truly belong in that category of exposure and individuals who are also misclassified. So when we consider our calculated measures of associations, which are reported as odds ratios and risk ratios, we're basing these on these observed measurements. And so the degree to which our estimates are reflecting the true association between caffeine and our reproductive outcomes of interest, of course, are going to be influenced by the accuracy of these measures. And this will also depend on whether or not the sensitivity and specificity of our exposure measurement tool differs between those with and without the outcomes of interest. So this is a table that's just basically a textbook example demonstrating it's basically demonstrating the impact of sensitivity and specificity on our observed measures. So when the truth would be an odds ratio of as great as 4.0, which is relatively strong, as we decrease our sensitivity and specificity, this has an impact on, in the case of non-differential misclassification, which is the situation where we had the same degree of error in our comparison groups, those with and without the outcome. We tend to underestimate, in general, we tend to underestimate our observed association. And I think that concept is relatively well appreciated, but perhaps what's less appreciated is that the degree to which this measurement error impacts our measures of association is also dependent on the frequency of exposure. How prevalent is this exposure in the population? So if you look across the first three rows, what we're seeing is with the same sensitivity and specificity, which would be considered at 90% relatively acceptable for most studies, we can see that as the prevalence of exposure decreases from about 36% to about 8%, right, we are dramatically decreasing the observed association. So it can have, and of course, prevalence of exposure, as we indicated in an earlier slide, this is very similar. The prevalence of exposure that we're seeing in general, pregnant women, about 10% of pregnant women are consuming the highest levels of caffeine. So this is certainly another consideration that we need to take into account when we're interpreting the reported measures of association. So there's a tendency to interpret all non-differential misclassification as producing bias toward the null, but I think it's important to take an opportunity to emphasize that this is only true when we have certain conditions in place, and that's when we have a binary exposure and we have no other errors that are correlated with exposure. And so certainly there have been many methodological papers that have demonstrated the impact that this misclassification can have, potentially even reversing the trends that we're observing. So quickly then, I also want to touch on differential misclassification, because our main concern, perhaps, if our focus has been on those studies that tend to report an increased risk associated with caffeine, are there scenarios where our misclassification can produce effects when in fact they don't exist? And so certainly, even under the simplest conditions where we have perfect specificity and imperfect sensitivity, when there is in fact no association in truth, we can produce an elevated odds ratio that's of a magnitude similar to those effects we're observing in several studies. And of course, if we take our specificity into account, we can increase that magnitude even further. So the bottom line, I suppose, of this message regarding exposure misclassification is that the direction and the impact is often unpredictable in terms of a qualitative assessment, because it can depend on several factors. The sensitivity and specificity of the measure in the cases, as well as separately, what is that accuracy in the controls, also the exposure prevalence, as well as whether or not we're dealing with binary or multiple exposures, because the point that I may have neglected to make earlier is that certainly most of our caffeine studies do not assess caffeine as a dichotomy, where we're evaluating multiple categories of exposure, and so we need to take that into account when we're interpreting this potential form of bias. So when we consider the modest associations that have been reported, and this is the table we saw previously, then certainly we have to take this into consideration. So one thing I would like to measure that mention is that despite this difficulty, there are quantitative methods that are available to attempt to address the impact and direction and magnitude of this potential form of bias, but unfortunately, they've not been implemented in studies of caffeine and reproduction. So to transition to the topic of spontaneous abortion, this issue of exposure misclassification has come up with regard to concerns about recall bias. So two of the most recent studies on caffeine and spontaneous abortion happened to be published in the same year. And so it so happens that the study that received the most attention reported a positive association for intake greater than 200 milligrams per day. But it was noted that in this cohort, which is described as a prospective cohort, that actually 59% of the miscarriages occurred before the caffeine was assessed in these women. And this is, a situation that is, difficult to address. You can enroll women in a study, and by the time you bring them back for a comprehensive questionnaire completion, then events will happen in the interim, and that's what happened here. So certainly there was concern for potential recall bias. And in the Savitz study, which was a similar study, a prospective cohort of 2,400 women, they encountered similar concerns or similar events in that 29% of the women happened to be interviewed after miscarriage, even though it was described as a prospective study. So this is important to keep in mind, too, that even our prospective studies often incorporate an element of retrospective reporting by necessity. And so in this case, Savitz stratified their analysis according to those who were interviewed before and after miscarriage. And in fact, what they found when they defined caffeine at the median was that those who were interviewed after miscarriage actually demonstrated that we observed an elevated odds ratio for this group, when in fact that disappeared when we only considered those that were interviewed after miscarriage. So certainly this provides some quantitative evidence concerning the impact of recall bias in studies of spontaneous abortion. And so here, just at a glance, we can see the variability of, based on another meta-analysis that should also be evaluated with caution. We see some variability in that distribution. So there's concern that this apparent consistency of a positive association could be due to common explanation, perhaps a common bias. And that major concern is what's been referred to as the pregnancy signal hypothesis. And that occurs when a healthy pregnancy may result in an increased hormonal response that increases the symptoms of pregnancy in terms of nausea and vomiting and aversions, which then changes behavior and ultimately decreases consumption. So the concern here is that the pregnancy signal is actually, or the caffeine consumption that we're observing in those at higher risks of these outcomes, it's a consequence of their unhealthy pregnancy rather than a cause. So as was mentioned earlier, there's concern for reverse causality. And this has been demonstrated, at least the association between symptoms and nausea and symptoms, or nausea and hormones and nausea and caffeine intake, this relationship has been demonstrated, and we see that it is, in fact, has differed in cases and controls in some studies. However, we have limited empirical evidence of the impact of this confounding by nausea and vomiting. So this is actually a very difficult issue to try to disentangle because we can't identify those that are destined to succumb to poor outcomes. We can't identify them and exclude them from our studies. So adjustment for nausea, unfortunately, has not eliminated associations in all studies, but other studies have provided some evidence for this effect. And so the evidence remains mixed, and more studies would be certainly useful. One thing that is lacking is an evaluation of the relationship between nausea and other outcomes beyond spontaneous abortion. And one study that has evaluated that association with fetal growth restriction was recently reported that nausea was not related to that outcome, and neither did the association between caffeine and fetal growth restriction differ by those with and without symptoms. Confounding by smoking is also another major concern, and I think this is well appreciated that caffeine and smoking are strongly linked, and smoking is a known risk factor for for many of these same adverse outcomes. But the major concern is that about a third of women fail to disclose their smoking during pregnancy due to the stigma associated with that. So when even though studies are attempting to control for it, often that's only dichotomized as a simple yes-no, and so we're not completely controlling for this important effect. And of course, this link between caffeine and smoking as well as alcohol has been demonstrated in other studies. So if we move on, of course, all of these limitations apply to the studies of the various endpoints. And so I've focused on those where the study or the outcomes have been more concerning with regard to fetal growth and miscarriage. But just briefly, I want to review the fact that preterm delivery in general, studies of preterm delivery have failed to produce elevated estimates of association. So we feel relatively confident in concluding that preterm delivery is not affected. Studies of subfecundity have varied in terms of their outcome, ranging anywhere from time to pregnancy studies to semen parameters, IVF endpoints, self-reported ovulatory dysfunction, and in general, these studies have not had consistent findings suggesting an effect between caffeine and subfecundity. Similarly, studies of congenital malformations have not been compelling. Studies for any single malformation have been limited, but generally those modest associations that have been observed are often relatively imprecise, and of course these studies are also susceptible to a number of biases. So in general, what did the experts conclude? The interpretation of the body of literature to date has been reasonably cautious, while the findings of the individual studies for some outcomes have been relatively mixed. The conclusions of the critical reviews have been fairly stable, even with the increasing number of studies over time. And that is, there's relatively uniform agreement that there's inconsistent findings which could be attributed to potential biases. And as a result of this, these advisory bodies have tended to take a precautionary approach to recommend limiting caffeine to moderate levels of consumption during pregnancy. So to conclude, I'd just like to quickly discuss the fact that the question really is, can we do a better job? Can we do a better job of putting these pieces together? Or are we at an impasse with regard to epidemiologic research in this area? And I would say that there is hope for improvement. There's certainly been a number of studies that have attempted, recent large cohort, prospective cohort studies that have attempted to make good progress with regard to improving on our exposure assessment. Of course, the best way to avoid exposure assessment is to avoid it by design. But with the nature of caffeine exposure, our limits are likely to continue. And so when these errors cannot be avoided, perhaps our best approach is to use statistical assessments, these bias analyses, to assess the direction and impact of the potential measurement error. Certainly other study improvements apply to new studies as well in terms of more comprehensive assessment of key confounders and biomarkers of smoking have been implemented in many studies. Also, we need a detailed assessment of the pregnancy signal, as well as more studies that attempt to enroll couples enroll couples attempting to conceive, so we can get at better assess those early pregnancy exposures and more accurately capture the 15% of losses that typically go clinically undetected. So in general, the validation studies that have been reported to date are somewhat insufficient, and certainly we can do so much more. So by incorporating validation studies, this would allow us to have a better assessment of the accuracy of our measurement tools while providing insight into the direction of these potential biases. There is one study I could identify that has assessed the accuracy of caffeine assessment in a cohort of reproductive age women. And in fact, they found the reported sensitivity and specificity. The sensitivity was relatively good, but the specificity was quite poor. And of course, we need more information with regard to women during pregnancy. And more specifically, this data would be most valuable if studies were able to conduct these validation studies in a subset of their own source populations to better reflect the accuracy in a given population. So, certainly I'm endorsing the advancement of methodological advancement that includes these bias analyses, which can improve upon our ability to quantitatively assess the potential for measurement error to explain our observed results. And this applies not only to misclassification, but also to situations where we have either unmeasured or potentially misclassified confounders. So while current conclusions do lack certainty, I believe we have room for improvement. And while we cannot completely dismiss the reported associations without stronger evidence for the direction and the magnitude of these potential biases, the current evidence suggests that these common susceptibilities to bias, may be sufficient to explain these observed patterns. So with some attention to methodological improvements, I believe we do have hope for advancements in our current interpretation of the evidence.
Dr. Peck's paper is now open for questions.
Zvonimir Šatalić, University of Zagreb, Croatia. I have two questions. Would you agree that FFQ is a much better choice than food record because of limited sources of caffeine when we do it in a large study?
I'm sorry, I didn't capture the food frequency compared to what?
Food records.
Food records.
Would you agree that's much better option?
By food records, are you referring to daily diaries?
I mean, diaries is a record, yes.
Right, okay. So the issue with, I think in general, real-time prospective assessment is considered to be, the best alternative. But when you're attempting to collect exposure over a long time period, of course you have issues with compliance and accurate reporting. So at the moment, I think one of the major challenges we have with validation studies is, of course, the fact that we don't have a true gold standard. Right, and certainly there are methods that can be used. There are probability methods that can be Bayesian techniques that can be used to estimate these distributions of probability to address that fact that we don't currently have gold standard. So typically the diary is used though as the gold standard as opposed to the food frequency questionnaire, which really addresses more habitual patterns over a longer period of time but won't capture changes during specific periods of pregnancy.
But we have caffeine in just a few food items, so it's much easier and it takes much less time.
Absolutely, that's why it's unlikely that unless we have some advancements with technology, which some of these methods are being developed with regard to tobacco exposure and tobacco epidemiology, using our personal devices and having apps where it's easier, at the push of a button to record what you're consuming and how much. I think these methods are being utilized to assess smoking patterns over time. And potentially, I'm not aware, potentially they're being used to assess caffeine as well. But I think there's some room for improvement even with regard to the daily diet record.
My second question would be, since all these dietary assessment methods have same sources of error. We have a huge problem with differences in coffee varieties, whether it is Arabica, Robusta, things like that. So when we use food composition tables, we have the same error in both. Are you aware of any validation studies that compared, for example, questionnaire with duplicate diet, or if you would do validation with biomarkers, which biomarkers would you choose?
Yeah, I believe, in fact, these studies that were reported also incorporated measures of caffeine metabolites, and I think there's some difficulty in translating, how the difficulty defining how the metabolites translate into dose of caffeine consumption. Typically, paraxanthine has been the metabolite most commonly used. It represents 80% of the metabolites that are produced during caffeine metabolism, but certainly it's not a perfect measure. So ideally, we have room to make advancements certainly with regard to the gold standard, and ideally it's likely to incorporate some combination of the two, some prospective dietary record in conjunction with using biomarkers, because biomarkers, while they may be an improvement in general over self-assessment or over self-report, they have their limits as well in that they only reflect recent intake.
Thanks.
We'll take one more question.
Thanks for a very complete review, John St. Peter, PepsiCo Global R&D. I'm going to ask a totally unfair question. You can decline to answer if you want. So the clinical question, so what do you tell your family member when she says, should I stop caffeine during my pregnancy or not?
Well, that's a good question, and I've encountered that, actually. Excuse me. That's the challenge, of course, right? And so I guess, the approach in general has been, well, there's one approach, and that's, the precautionary principle. Until we can confirm that there are safe levels, then we can recommend being cautious. And I suppose that's the approach that most people take, and in fact, I believe that the advisory boards have taken. There's definitely, I would say, there's agreement that the evidence for effects at low consumption levels are not convincing. The question is whether or not there is an impact at over 200 or 300 milligrams per day. In general, most of our population is not consuming quantities greater than that. So
what do you tell your daughter?
So I'm sorry?
So what do you tell your daughter?
What do I tell my daughter? I would say, well, I'm an epidemiologist, and so I'm trained to be skeptical. And so, I personally drove my own husband crazy when I was pregnant because if we don't know, then I say avoid it. And so my own personal approach, was to not accept the fact that there's no evidence because often it hasn't been sufficiently evaluated. So for me, that expanded to a number of issues. I would hesitate to make policy as an epidemiologist. I'm not trained in the ramifications of making a policy decision. Only, really, my focus is on the methodologic issues, evaluating exposure disease associations. And so I would certainly, in general, interpret the evidence as not sufficient to produce high levels of concern.